Good afternoon, everybody, and welcome to Maine Health Management Coalition's webinar today, Specialty Pharmacy, Understanding the Business Model and Why It's Important. My name is Marie Stuckey. I am the Member Relations Specialist here, and I just want to go over some quick business first to let you know that this presentation will be recorded and available on our website. And if you have any questions during the webinar, feel free to just type them in the chat box at the bottom of your screen, where we will make note of them and ask them at the end during a question and answer period. I will just go ahead and give a little bit of background on the coalition for those who are listening that are not familiar with us, and a little bit of information about things that are going on for our members as well. The coalition's mission is that we are a purchaser-led partnership among multiple stakeholders working collaboratively to improve health and to maximize the value of healthcare services for the employees and dependents of coalition members and all the residents of Maine. It's our vision to lead the country in population health status, patient care experience, and low per capita healthcare expenditures to support a healthy economic climate here. Being a multi-stakeholder group with over 70 members, we are divided among purchasers that again lead us, health plans, brokers, benefit consultants, providers, affiliates, and consumer members. We achieve our mission through several different work areas, and our data department is the foundation for all of that improvement. One of our initiatives is transparency and public reporting, which is available to be seen on our Get Better Maine website, where we publicly report the outcome, safety, and patient experience and cost ratings for providers in the state. We also reach out to consumers to engage them through various means, such as book clubs, competitive wellness programs, and other similar programs such as that. We also focus on changing the benefit design plan options in the state. We're developing a new plan with all the major health plans in the state, value-based insurance design, and this is to identify key patient and provider benefits and reimbursement incentives and reward for high-quality patient-centered care. We also have a payment reform group on staff that works with our collaboratively with our members on alternative payment arrangements with providers, hospitals, and systems to, again, reach that goal of high-quality, patient-centered care at a reasonable cost. As a member of the coalition, there are several opportunities to network, learn, and influence by getting involved in any of our work groups and committees, signing up for any of our newsletters, such as our broker or member newsletters, taking advantage of training opportunities, and other networking events that we are constantly working to develop for our members. One of those events, which is the biggest one, is coming up this fall. It's our annual symposium. Please save the date for November 18th. It will be held in Portland and is titled Leading Change: How to Make the Switch from Volume to Value. Here's a listing of our current members, and you can also find this on our website. And here is just a graphic showing some of their great logos, and we appreciate the support that they give us. Some of the benefits of membership are the ability to network with other Maine health and business leaders, to identify best practices, access our outstanding data team analytics services, to train leadership and staff through education events and resources that we provide, to guide staff to high-quality, reasonably priced healthcare-related services, and brand your organization as a pioneer in support of Maine's economy and health. As I mentioned, there are many work groups that our members get involved with, and of course, since you're on this call, you are aware that we also offer our members free access to all of our educational webinars, sometimes with continuing education credits. Our members, of course, have influential voting rights for our board and for some of the work group decisions that we work on. We also offer some discounted fees on conferences and other opportunities. Our members did achieve savings in 2013 for hospital safety based on the Leapfrog Group hidden cost calculator of over $7.6 million. So I'm very pleased to give you a little background on our presenters today. We have three presenters. I'll just give you a quick overview on them and then hand over the presentation to them. First, we're going to hear from Mike Krause, the Regional Sales Vice President and from the Northeast region for Navitus. Mike's responsibilities at Navitus include managing new client development in the northeast part of the United States. He provides and explains to potential clients the alternative of managing their pharmacy benefit through Navitus's full pass-through business model. Prior to joining Navitus, Mike was the Director of Sales for Benecard Prescription Benefit Facilitator in Clifton, New Jersey. While there, Mike managed all sales and marketing activities related to consultants, unions, and commercial markets in the Northeast. He also oversaw the implementation of a customer relations management system and sales automation process. Mike has over 20 years working in healthcare sales at the Seneca Group, National Medical Health Card, Multiplan Inc., and the Empire Blue Cross Blue Shield, among others. Sorry if there was a technical glitch there for a moment. He has in-depth understanding of his clients' unique pharmacy benefit management needs and a Bachelor of Science in Hospitality, Sales, and Meeting Management from Johnson & Wales. He holds a New York State Life, Accident, and Health license. And he resides and works in Ridgefield, Connecticut. So we're also going to be hearing from Sunny Ghali, Clinical Pharmacist Resident at Navitus Health Solutions. Sunny is the Clinical Pharmacist Resident, as I just mentioned. Okay, I'm reading this, obviously. His term as a resident at Navitus has included working with preceptors among the various departments, with responsibilities such as presenting hepatitis C drug class review and Harvoni drug monographs at a recent Pharmacy and Therapeutics Committee, as well as extensive support of Navitus Specialty Pharmacy, Lumicera Health Services. Sunny received his Doctorate of Pharmacy from Regis University and his Master's of Business Administration from DePaul University. He also has a Bachelor's in Business Management from Purdue University and has recently accepted a position in Industry Relations and Contracting Manager at Navitus. In this position, he'll be working with the Strategies Department at Navitus as well as pharmaceutical manufacturers to manage rebates on behalf of their clients. And finally, we've got Sharon Faust. She is the pharmacist in charge at Lumicera Health Services, and in this position, been in this position since 2014, and she manages all daily operations within the pharmacy, including overseeing and clinical training of all staff members. She continues to improve clinical pathways, including designing and implementing a novel patient management program for each specialty drug dispensed, encompassing a variety of patient management principles. Her responsibilities also include ensuring compliance with all laws and regulations governing the operation of Lumicera, including licensing. Prior to joining this group, she worked as a pharmacist for Walgreens for more than 7 years and conducted comprehensive medication reviews for patients with complex therapies, and also provided patient-centered consultations on prescription and over-the-counter medications. Sharon received her BS degree and Doctor of Pharmacy degree from the University of Wisconsin-Madison School of Pharmacy. She's a licensed pharmacist in Wisconsin and is an active member of multiple industry organizations, including American Pharmacists Association, Wisconsin Pharmacy Society, and the American Society of Health System Pharmacists. With nearly 10 years of experience in pharmacy management, Sharon brings targeted industry expertise to Lumicera. And with those introductions, I'm happy to now pass the presentation over to this group who will present to you.
So thanks, Marie. This is Mike Krause from Navitus. I just want to make sure that we're on the same page here in terms of what's being shown on the slide, because I'm not seeing the screens advance here. So unless it's some technical, there we go, perfect. Okay, so let's move along to the next slide here. Before we get involved, obviously we thought it was important to give you a quick overview of our organization and who we are. So Navitus Health Solutions, we're a PBM based out of Madison, Wisconsin. We have offices throughout the country, including Austin and Phoenix. We are a full-service pharmacy benefit manager, or PBM. We were founded in 2003 by 2 health systems and 2 managed care organizations based out of Wisconsin. Today, that health system ownership, if you will, is still very much a part of our DNA and who we are, in that we are owned by SSM Health. They're one of the Midwest's largest integrated health systems. They employ over 30,000 people. They own 150 hospitals, an accountable care organization, 18 hospitals, an accountable care organization, about 150 some odd clinics, and of course a PBM being Navitus. So Navitus, we've been widely recognized as setting benchmarks for both service and transparency, and it's something we're quite proud of, especially in an industry that's really been plagued with controversy in just about every front, if you will. We serve over 4.25 million members, and what I just mentioned has a lot to do with that growth. All of our clients are serviced on a 100% pass-through and transparent business model. So for purposes of this discussion today, for specialty, what that translates to is a cost-plus model. And we'll talk about that a bit more later, but that's really one of the 2 business models that are available in the market today. We currently manage the benefits for Community Health Options, which many of you may recognize. So that's formerly Maine Community Health Options. They recently changed their name to better describe the members that they're serving, not only in Maine, but New Hampshire. But so today we administer the pharmacy benefits for those folks and their 75,000 members that they serve. So Lumicera is our own specialty pharmacy that we opened in 2014, early 2014, full service specialty, and as does our underlying PBM services, Lumicera provides the market with an alternative to what's been available in the last 20 years or so. So it's a transparent, it's a cost-plus delivery of specialty drugs. And of course, this delivers the same industry benchmark setting level of service, if you will, that our core PBM function does as well. So the objectives for today, why you guys signed up for this session here. We want to help you understand specialty drugs and how specialty spend is changing the market. Obviously, pharmacy trend is taking a significant rise as of recently, and this is primarily due to the increased cost of specialty. So we're going to help you understand how specialty patient care and the different pricing models, including both the traditional and the cost-plus model, and then we're going to help you understand suggestions in terms of how selecting the right specialty and PBM partner can help you reduce costs and provide quality care for your members, for your employees. So with that, I will turn it over to Sharon and Sai.
Thanks, Mike. So let's start off by defining what specialty is. So there's no clear-cut definition of what specialty medication is, and what you see here is how we define specialty meds. It could be an injectable, oral, self-administered, or administered by a healthcare provider. Also, these medications are complex to manufacture. Sometimes they require special handling and administration, as well as they're only available through limited distribution channels. Many of these meds also require ongoing clinical support by pharmacists and doctors, and these meds are taken by a very small percentage of the population, but are significantly higher in cost than compared to traditional medications, which is a big area of concern for payers. And not to digress too much, but there's just 2 terms that I wanted to cover that kind of pertain to this slide in terms of self-administered or administered by a healthcare provider. I'm not sure if anyone's heard the term brown bagging or white bagging, but essentially brown bagging means the medication is sent to the patient and the patient brings the medication into the doctor's office for administration. And white bagging refers to the pharmacy sending in the medication directly to the doctor's office for administration. Across our book of business, what you see here is what we see in terms of specialty trends. About 1 to 2% of our claims volume pertains to specialty, but it encompasses about 20 to 25% of our costs. What we've seen, though, is a significant cost shift from traditional brand medications to specialty products. And furthermore, the use of specialty meds and costs have continued to increase. When we take a step back and look at the industry as a whole, a lot of analysts cite that specialty spend will quadruple by 2020. And what you see on the graph on the bottom kind of depicts that. In 2012, we spent about $87 billion, and this is industry-wide again. In 2016, it's projected to be about $200 billion, and then by 2020, analysts anticipate an expenditure of about $400 billion.
One of the driving factors for increased specialty drug spend is also the increasing price of the existing products available. For instance, in this diagram you can see the XR gel used to be $700 per vial in 2007. That price has increased in 2014 to about $32,000 per vial.
This slide this slide depicts the types of drug approvals by the FDA over the past 6 years or so. And what you see, what's interesting to note is in 2010, specialty drug approvals exceeded traditional, and it's been consistent since then. So we expect this trend to continue to increase as well. So we ask ourselves what really is driving these trends, and it's kind of twofold. First is specialty drug price inflation, meaning manufacturers increase prices for existing specialty drugs. And this may be attributed to the lack of generics available as these specialty products mature, as well as stagnation in the approval of biosimilars, which is what we'll cover in a few slides, later on in a couple of slides. Also, annual drug costs can be significant for some disease states, which is what we'll also cover later in this presentation. There's also increased utilization. We see a flourishing pipeline, as well as new indications for existing specialty drugs, and the introduction of high-cost narrow niche drugs to the market, as well as increased public awareness of these chronic disease states, which overall drives utilization of these medications. Here's a breakdown of the FDA approval pathways for small molecule drugs as well as biologics. And of importance, I want to point out the biosimilars. Just to quickly define it, biosimilars can be kind of outlined with the act that was passed in 2009 called the Biologics Price Competition and Innovation Act. And essentially this states that drugs must demonstrate similarity to the reference drug and have no clinically meaningful differences in regards to safety, purity, and potency of the product. Some biologics can be referred to as orphan drugs, and these are medications used to treat rare diseases. Currently, there's over 300 orphan drugs in clinical trials, and about 40% of these drugs can be considered specialty. Many manufacturers also receive incentives to produce these types of medications. Just to define, just to kind of provide a big picture, orphan diseases only affect, well, only less than 200,000 patients in the U.S. And these are conditions for which there's no or limited therapeutic options. They tend to be genetic in nature, and sadly, this statistic states that only 30% of children with an orphan disease will die before the age of 5. The FDA approval process is a bit different for orphan drugs. They rely more heavily on pivotal trials due to the small study populations, and some examples can include cystic fibrosis or Gaucher's disease.
While orphan drugs are a key driver in the specialty spend, there are additional drug classes currently in the pipeline that may have a large impact on our specialty spend in the near future, and I'll just go over a couple of those drug classes here. The PD-1 and the PD-L1 inhibitors you may hear about. These are monoclonal antibodies, so biologics, injected intravenously for chemotherapy, so lung cancer, melanomas, breast, bladder, and other cancers. The breakthrough aspect of these is recently they have demonstrated efficacy in phase 1 and phase 2 trials in lung cancer. This is a large portion of the cancer market, so it does have the potential to create projected expenditures of $8 billion and $6 billion respectively for the two medications that are on the market right now, and that is for lung cancer alone in 2020. An additional drug class that may have some impact in specialty spend are the PCSK9 inhibitors. These are also monoclonal antibodies subcutaneously injected for the use of high cholesterol. This has the potential to have a big impact due to the large percentage of patients with the diagnosis of high cholesterol, and also they are very effective. So very effective in their use, and how this specialty spend will play out will have to do with how the FDA restricts the indication. So whether they have a broad or narrow indication for the high cholesterol will affect how this affects our specialty spend.
So we've also observed a significant growth in the number of specialty meds for a given disease state. And this graph basically highlights how many more specialty drugs there are available now compared to about 10 years ago for a given disease state. You can see for pulmonary arterial hypertension in 2004 there were 2, and by 2014 we had about 12. And then for multiple sclerosis we had about 4 in 2004, and then in 2014 we have about 10. And to kind of tangent off the number of specialty drugs available, many of these diseases also require a complex treatment regimen. For example, Hep C. It affects about 3% of the world's population, with about 3.5 million people in the U.S. It causes about 350,000 deaths annually, and the vast majority of the patients in the U.S. have genotype 1. If you look at the chart on the right, you can see that about 74% of those patients in the U.S. will have genotype 1, and then it breaks down even to a subgenotype of 1A or 1B, whether or not they're treatment naive or treatment experienced, as well as whether or not they're cirrhotic or non-cirrhotic. The important thing to point out, though, is that each of these subtypes can have varied treatment durations, adding to the complexity of treating these patients. Over the past year, we've seen the introduction of some new treatment options for Hep C. For example, Harvoni, which is produced by Gilead, and Viekira, which is produced by AbbVie. And the reason we consider these specialty medications is first and foremost the high cost, as well as they require intensive clinical management, especially when it comes to adherence. Any gaps in therapy can result in treatment failure. And then finally, distribution of these medications is limited through specialty pharmacies.
I'll now talk about the specialty fulfillment process and how specialty pharmacies may distinguish themselves in comparison to retail pharmacies. The following will be a process that Lumicera follows and what we feel is best practice. So the prescription arrives at the specialty pharmacy, and the technician reviews and enters it into the system and conducts any benefits investigation with the insurance, whether or not a prior authorization is required or any sort of copay assistance that may be needed with medication. The pharmacist then performs the first verification. This would be any sort of dosing check, making sure that the prescription is accurate, the patient information is collected. For example, oftentimes we're seeing that the newer medication, Actemra, is not prescribed based on the weight-based dosing recommendations. So this would be where the pharmacist may make that intervention and contact the provider to get that corrected and the correlating cost savings with that intervention. Then once the prescription has been checked, the care coordinator calls the patient to confirm any shipping information, a need-by date or start date, discuss any clinical issues, and provide the clinical pathway or the clinical questionnaire. And this is questions that are, and information that are addressed by both the technician, the care coordinator, and the pharmacist as well. After that, the pharmacist would perform a second verification on the product itself to make sure that there are no product errors and to make sure that the integrity of the product is to the highest quality before sending it out. And finally, the medication is packaged and shipped directly to the patient, or in the white bag scenario, directly to the provider. So in the specialty pharmacy world, there are a couple key components that distinguish specialty pharmacy. So in specialty pharmacy, we want to prevent gaps in therapy. Adherence is of the utmost importance. If we are spending the money on the medication, we want to make sure that we are getting the most out of it. We have refill reminders, proactive calls out to the patient, as well as delivery coordination to make sure that the patient is expecting the delivery when it does come to them. We have insurance verification and the benefits investigation that I described earlier. There's also patient assistance programs. It has been shown that based on a patient's income, anywhere between $100 to $200 potentially can have adverse correlation with therapeutic outcomes and how adherent a patient is on a medication. As well as clinical interventions, I did talk about adherence and how important it is, motivational interviewing to increase that adherence, patient proactive education, as well as the psychosocial assessment. At Lumicera, we do have customizable clinical pathways. So these are questionnaires and data gathering that are set up at both the drug and the disease state level. The pathways can be set up by fill number, date or time frame. So we usually have an initial assessment, a 7-day to make sure that the medication arrived and the patient has started it, 21 days to assess side effects or initial side effects, and then monthly follow-ups. With these program triggers, the technician may perform a general background and information collection, and the pharmacist will touch base with the patient on any clinical information, as well as addressing any questions or concerns regarding therapy. All this information is stored into the pharmacy system for future communications with the patient, as well as data collection on efficacy and adherence. This slide just kind of brings together some of the clinical management specialty aspects for any sort of program. So with the clinical pathways that I just discussed, on the specialty pharmacy side of things, we're aiming to increase adherence to therapy, monitor any adverse events or side effects, and improve overall outcomes of therapy.
Yeah, and on the more so on the PBM side, when it comes to product selection, we want to make sure that medications are being used in accordance with P&T recommendations, and we facilitate formulary changes and the use of biogenerics and biosimilars as available to mitigate costs.
Specialty pharmacies can use waste management programs to identify dose changes and discontinuations prior to dispensing any additional medication, preventing waste that way. You can also use clinical assessments and pharmacist interactions to assess duplication and effectiveness. If a medication is not effective, I can make an intervention or proactively discuss possible switch of medications. as well as data integration. So collecting data both in the pharmacy claims as well as the data collected from clinical assessments.
And finally, when it comes to prior authorization and formulary decisions, the P&T determines the prior authorization criteria as well as formulary placement. And then the PBM also makes the PA determinations in order to support clinical management. So now we'll transition into the different types of pricing models. And I'll briefly talk about the three types. First, there's the traditional AWP, which is average wholesale price minus. And this essentially refers to one discounted price across the board. And this works well if drug prices are within a tight window. However, with specialty drugs, we see that this usually isn't the case. The next pricing model is the AWP over WAC, so average wholesale price over wholesale acquisition cost per individual product. And it's essentially a discount based on the individual drug. It's slightly more competitive than a traditional model and encompasses preferred agreements with certain products. Finally, there's the pass-through cost plus model, which is what our specialty pharmacy, Lumicera, follows. And this encompasses three different components. First is the actual drug acquisition cost. Then there's a set patient management fee. And then finally, the shipping costs. And Sharon will discuss in detail the pass-through cost plus model.
Okay, so using Navitus and Lumicera's position on transparency, Lumicera does use the pass-through cost plus model. The first of the three components that Sunny briefly touched on is the drug actual acquisition cost. So this is calculated on using a first in, first out accounting method. So if a drug comes in at a specific price and then a week later there's a price increase on it, the claim is billed at the actual acquisition cost and not the increased price of the medication. There's a full audit. Client can have a full audit of the claims and attach them to specific purchase orders if need be. Any discounts or rebates that are determined after the claim is processed, those are 100% rebated back to the client. So the client would see those savings instead of the pharmacy taking those. The second component is the patient management fee. These are fixed fees and they're drug specific. So these fees vary based on a couple of factors. The complexity of therapy at the drug level, so how much outreach is needed to maximize the efficacy of that medication. Is it a one-time versus a maintenance therapy? What's the storage and the delivery parameters? And how many ancillary supplies like needles, syringes, or swabs are required? All of these costs and the profit are tied into this patient management fee. So the cost of the supplies and the revenue is in this patient management fee. The last component is the shipping costs. So with the shipping costs, because they are not known at the time of adjudication, they are estimated and then squared up after the fact. So all of the shipping costs are passed through to the client at the actual shipping cost. And like I said, they're squared up for a net zero balance after the fact, just based on the timing of the adjudication. So the estimates are drug specific, so whether it needs cold chain refrigeration of the product or not in various factors to that account. Also, any rebates available from the carrier, so UPS or FedEx or any rebates at that are rebated back to the client as well.
So tying in the different specialty pricing models that we just discussed with our Harvoni example, we can kind of see the estimated cost for each. The average wholesale price of Harvoni is about $37,800. And with the traditional pricing model, you'd expect to see somewhere around 16% off the AWP, which would be roughly $31,800. With the slightly more aggressive model, with the per individual product, you may gain another percentage and see a cost of around $31,400. But we see the most savings with the pass-through cost plus model. Essentially, you'd see, in roughly estimating, around $30,700 because all the drug costs are essentially passed directly back to the client. I won't go into too much detail or read off the slide here. I feel like we've covered these, but what I want to do is kind of summarize that these are all the components that we feel play an important role in managing trend. The key point is that there's no silver bullet, and that a well-planned and executed combination of these 6 things will help control costs on when it comes to specialty medication spend. And Mike, I'm going to pass it back over to you now.
Sure. So, you know, in summary, I guess if we were to wrap this up with this slide, I think the underlying, you know, position is that it's important to select a specialty provider and PBM that, you know, aligns itself with its clients through a business model that, you know, allows for transparency. And that's just not just you know, financial transparency, but also, you know, operation visibility, transparency. So why does the entity that the specialty pharmacy make the decisions that they do? You know, as a plan sponsor, as a payer, you should have access to that. And if it's, for whatever reason, if it's something that you as a plan sponsor disagrees with, or the approach for some unique characteristic about your organization doesn't make sense, you're afforded the option, you know, to change it. An example would be, you know, health systems or entities that have their own internal assets, be it a pharmacy, you know, where they may be able to secure certain products and dispense them to their employees, you know, at a lower cost and provide more of a high-touch service. It may also be, you know, a local community provider, such as the case with, you know, with Maine Community Health Offices that we work with, that it's decided for cultural reasons that that is a better fit for your population. So, you know, we feel that you know, that's an important consideration when selecting a specialty provider. And ultimately, this can allow you to, you know, select a partner that's going to deliver the ultimate value and lower net cost than, you know, the rigid specialty pharmacy and general PBM approach that the industry has really been forced to adopt for the last, you know, decade plus. So at this point, I believe we're on to the Q&A session. So we're happy to take any questions that you may have.
Oh, thank you to all of you, Sharon, Sunny, and Mike. Appreciate it very much. And I will remind everybody that if you do have questions, you can feel free to go ahead and type them in the chat box, and I will relay those questions to our presenters. To begin, we do have a few questions. The first one is, what is the patient cost-sharing tipping point in out-of-pocket expense above which patient abandonment increases?
So there have been some articles and some research points on what that price point is. Obviously, first of all, it does depend. It would depend on what the patient's annual income is. First of all, usually we see, like I said, between the $100 and $200 mark at a per month copay is kind of the break point for when a patient may fall off adherence. Maybe they dread getting that next refill because it's going to cost them that additional money. The one thing about this is that the manufacturer copay cards do make it difficult to judge the impact of a high copay on the price point for the patient, especially since on the claims adjudication side, maybe on the PBM, you may not know whether or not a copay card is being used. But in pure out-of-pocket cost, it tends to be in that $100 to $200 range, depending on income.
Okay, great, thank you. Here's another question that's just come in. How does the pharmacy manage patient appeal letters to the PBM, and how does the PBM work with appeal letters to cover medications on a case-by-case basis?
So I believe the question may be asking prior authorization appeal. Is that what you're thinking?
Is that what they're referring to?
Or
okay, I'm looking back at the question here. I don't know if the person who wrote it wants to clarify, but I'm basically just reading it to you. So how does the pharmacy manage? Go ahead.
Sorry. Read it one more time.
Sure. Yes, they are confirming that the question is, how does the pharmacy manage patient appeal letters to the PBM, and how does the PBM then work with the appeal letters to cover medications on a case-by-case basis?
Well, on the PBM side, I know that we have a committee that meets to discuss appeals. I can certainly get more information on that and get back to the requester. I don't have too much knowledge or detail in regards to exactly how that process works.
On the pharmacy side, we would handle appeals by essentially giving the information for the provider between the go-between between the provider and the pharmacy benefit manager, Navitus, in our case, and just help them in that process. Once that appeal is approved, we have kind of direct communication between the PBM and the pharmacy to get that claim adjudicated and the patient started on therapy as soon as possible. So the pharmacy does act as kind of a go-between between also not only knowing the knowledge of the PBM and what the PBM is looking for and communicating that to the doctor, but also if that appeal is approved through the PBM appeals process, the patient can get on therapy quickly and not have any delays between approval and dispensing.
Yeah, and to kind of build off of what Sharon said, there's close collaboration between the pharmacists that do the prior authorizations and the clinical team at Lucero. So sometimes I know that proactively the team and the PBM team will reach out to the pharmacy and let them know that a PA has been approved, so that there's no delay in starting the patient on their medication.
Great, thank you. Okay, we're getting a bunch of questions coming in. What are we hearing from consultants and brokers regarding acceptance of our model versus traditional with competitors such as Accredo?
That's a great question.
Mike,
yeah, maybe.
Sure. So it's a very, very good question. I would. It's really the consulting community that's accepted our model are a subset of individuals, but that subset is growing tremendously. So this is in some ways our model is very much described as a disruptor to the industry because it is very different from what payers have been trained to measure and the way they've been guided to purchase pharmacy benefits and specialty pharmacy in general. So, but the results are in for the growing number of clients that have adopted our pricing methodology, and it's gaining a lot of traction. It's opening a lot of eyes for the sole reason that we see time and time again that it delivers a lower net cost, but it's a different way of evaluating the RFP tied to this kind of thing, and that takes a bit of time to get the consulting community educated and comfortable with what we deliver.
Okay, great, thank you. How many Navitus clients have a specialty tier, and what is the copay or coinsurance level for that specialty tier?
Mike, can you answer that, or?
Yeah,
Okay.
I mean, honestly, I don't know that off the top of my head to even honestly give you a true feel for what the percentages are. That's something I'd be happy to connect with our client services team who manages, our clients and would be more, intimately familiar with the plan design tied to specialty. I do know that we do have, there certainly are clients that have a fourth and fifth tier that incorporate specialty, but I don't know what the percentages are in relation to our book of business. But we're happy to follow up with you on that.
Okay,
And
thank you.
I think that, go ahead.
No, go ahead.
I think a majority or a vast amount of them do have a specialty tier or have some sort of specialty mandate. And the cost point on those specialty medications differs greatly between from client to client. There's no one kind of universal copay structure. Each client can kind of choose their own price point.
Okay, great. We did get another question here. How does Navitus offer the cost plus pricing model to contracted pharmacies besides Lumicera?
So the cost plus pricing model is only if the client chooses to go with Lumicera. So currently, if Navitus contracts out with other specialty pharmacies, they would not have the cost plus pricing model into their specialty program. They would be using the WAC minus, or the AWP over WAC pricing model. So it only is with Lumicera. So if they go with Navitus and Lumicera.
And that's a great question. I'm not sure that we have been approached by any entity to contract with us on that front. So that may be new territory for us. But I think it's important to at least note that.
Great, okay. Can you tell me about the effect of biosimilars on specialty spend?
I say that with the trend of where we're seeing biosimilars in the pipeline, I would say that they're not going to be significantly cheaper compared to the reference drug, but there may be some attainable cost savings, but I think that's yet to be seen. However, I still think that the trend's still going to be on the upward as opposed to leveling off.
What else can PBMs do to help control specialty medication spend?
I'm sure there's plenty of opportunities that exist to control spend. It really depends on how innovative you want to be with your specialty pharmacy. Some examples could include adherence programs. I don't know what else.
Yeah, I didn't touch on the split fill program on the PBM side. So certain oncology tablets, because they may be not, they may have such great side effects associated with them that you may have split fill kind of 15-day supplies instead of 30 as a waste management program. That's another thing you could do that I didn't touch on. There's kind of no end to the innovation that you could provide with specialty programs. So I think that everyone's looking for kind of the next best program to reduce the specialty spend trend, or at least kind of curve it down a little bit.
Okay, thank you. We're getting lots of questions here. This is great. What kind of outcomes reporting does Navitus offer their clients? both by client, BOB, and industry benchmarks?
I think there's, just from what I know from my experience as a resident, I think there's a wide variety of different types of reports that we can provide. And I know that we have a lot of customizable reports as well. So I don't think there's a black and white answer to that. What I can say, though, is that you know, we always try to accommodate whatever requests the clients may have. So if it's their particular type of report that they're looking for, I know at least on the Navitus side, we do our best to make sure that they get whatever information they want. And it kind of follows suit with our transparency model.
Now, to add to that too, please keep in mind that we introduced Lumicera, you know, just over a year ago now. So benchmarking compared to, you know, our specialty partners that are still available to our clients, by the way. This is not, you know, clients that work with Navitus have a choice. You know, this is a choice for them to use Lumicera, you know, because it's not a profit center for us. You know, we make it available as a choice, but we don't, you know, we're just starting to get some of the data in compared to costs tied to the two specialty partners that we've historically used, and we're seeing a savings of, you know, between 1% and 2% on the specialty spend, you know, year compared to a year prior. And of course, you know, as stats come out going forward, that will be shared, you know, publicly into our clients as well.
I know that Navitus.
Oh, go ahead. Go ahead.
Oh, Navitus does have some measures that it can report back on a client basis. Obviously, specialty spend products, as well as adherence measures like PDC and NPR. Those are available for clients as needed, or on, you know, on their yearly report.
All right. I'm going to move forward with another question here, if that's okay.
Yep.
The site of care, or basically the location where the specialty prescription is administered, is a significant issue with a wide variety in markups. Is influencing the most cost-effective site of care something specialty PBMs can help with?
I'm not sure.
There's a couple.
I'm sorry, go ahead.
So I believe that the question is referring to sites of care in terms of infusion, medical clinic, at-home infusion, and self-administration. Those are some areas of sites of care that have some increase in specialty trend. As far as if the PBM can control those costs, maybe yeah. Sunny or Mike can talk to that. I know that, you know, you do have medical benefits, and then you can do medical carve out into the PBM space.
Yeah, but just from my understanding, it seems like if it's something that's going to be administered in the doctor's office, it probably fall under the medical benefit as opposed to on the PBM side. And I don't know if Mike, if you could shed some more insight into that.
Yeah, I know that we you know, with some of our health plan clients and you know, that really control the network, we've collaborated on that front, you know, to coordinate with those providers. But, you know, other than that, I don't believe that there's been a whole lot that we've been able to do. Although, you know, one of the things you have to remember is because of, again, the fact that the Lumicera is not a profit center for us, or a significant profit center, I should say. It's you know, we will take a much more collaborative approach than, you know, perhaps some of the other PBMs and specialty providers, you know, to come up with some unique programs to address that. And maybe it's you know, it's working with those providers in the medical side of the network, and wrapping some of our services through Lumicera around that.
Thank you so much. I think we have time for just one final question, and then we're going to do a short poll that we'll share the results of with everybody, just to kind of see what kind of topics people may be interested in for upcoming webinars. But the final question here is, how long can we expect specialty medication spend to continue increasing?
As far as we see right now, at least for the next foreseeable future, and considering the drugs that are in the pipeline and just the way that the market's going, I would speculate that it's probably going to continue to rise. And so it's important to take into account and try to at least try to get ahead of the curve. I don't think there will be a time, at least in the foreseeable future, where specialty spend won't be a concern. Just looking at the number of FDA approvals, looking at the new indications that are coming out for existing medications, as well as the ones that are in the pipeline.
And to add to that, some of the benefits that manufacturers get from having orphan drug status are large money makers for those manufacturers. So I think that area has the potential to grow and continue to grow.
Great, thank you so much. I really want to thank our presenters today. Great, rich discussion, too, of questions. Thank you for the people who've attended and asked great questions as well. So if you would take a moment, we'll share with you the outcome of this poll, which I'm going to launch right now. Which future webinar topics are of most interest to you? And we'll just give you a quick minute or two to vote on that or to fill it in, and we will share the results with you. Okay, I'm going to be closing the poll now. And here are